Chris es originalmente enfermera, tiene más de 30 años de graduada, tiene doctorados, maestrías y es realmente una experta en este tema. En Estados Unidos hay una empresa muy, muy conocida que se llama Press Ganey, que ella nos va a explicar qué es esta empresa, pero hay varias herramientas para hacer esta especie de encuesta, de cuestionario que le envían a los pacientes para recaudar cómo ha sido la experiencia, esta especie de survey, de cuestionario, de preguntas, donde el paciente contesta y estas empresas expertas son capaces de orientar a las autoridades del hospital sobre cómo están siendo percibidos por el usuario y cómo mejorar esa percepción. Esa percepción no es necesariamente por la reputación para recibir más pacientes, es porque está claramente relacionada, como van a ver, como se ve hoy en día, los resultados demuestran que esto está absolutamente relacionado y que nosotros no debemos solamente estar pendientes de la calidad del servicio. La calidad es algo que se sobreentiende hoy en día. Hoy en día no es solamente la calidad, tiene que ver con la seguridad la seguridad que se le da al paciente y tiene que ver con la medición de la experiencia, de la satisfacción del paciente. Y ella de alguna forma ha tratado de correlacionar la experiencia con el grado de sufrimiento que siente el paciente. En vez de decir si la experiencia fue buena o mala, saber cuánto sufrió el paciente y cuánto sufrió el médico y el personal paramédico prestando ese servicio. Y hoy en día ellos tienen mecanismos para medir ese sufrimiento y pueden saber qué tanto está sufriendo el paciente en forma innecesaria, donde nosotros en forma involuntaria le estamos generando más sufrimiento al paciente cuando lo hacemos esperar, cuando espera un resultado de una biopsia, cuando no respetamos la privacidad del paciente, cuando no consultamos a él. Hay una serie de cosas que ellos ya saben que generan sufrimiento innecesario al paciente. Entonces, por supuesto, después de que salí de la conferencia, pues les quiero decir que es probablemente una de las conferencias más impresionantes que he escuchado en mi vida. Chris, this is one of the best talks that I have ever heard in my life. And que quedé más impactado realmente al escucharla. Y por supuesto fui y me compré el libro y me lo he leído y lo tengo todo subrayado, todo marcado. I have made lines and notes. Porque definitivamente sentí que había alguien que me entendía y que definitivamente mi sentimiento era compartido. Y ustedes saben que siempre he estado insistiendo en que es muy importante nuestra conexión con los pacientes, que seamos amigos de los pacientes. Entonces, por eso le he pedido a Chris si podía, tenemos este diálogo, porque en Latinoamérica esto no es muy conocido. Y yo le he pedido a ella si su libro estaba en español, porque era algo importante que nosotros en Latinoamérica, y Press Ganey no trabaja en Latinoamérica. Ellos tienen hoy en día en China y en el Medio Oriente. Y yo le decía que era muy importante, y yo estoy seguro que en México, en Colombia, van a haber empresas editoriales interesadas en ofrecerle a la empresa editorial de McGraw-Hill que hizo si podemos traducirlo y si se puede adaptar a la cultura latinoamericana, porque hay mucho que aprender para mejorar nuestros servicios médicos y la satisfacción de nuestros pacientes. Y nosotros tenemos una gran ventaja porque nosotros generamos vínculos muy especiales con nuestros pacientes. Chris, I give a basic introduction, and I also encourage them that we should translate this and we should help to find who can do it in Spanish. And we already have an advantage because we are very close, very warm with our patients, and that helps, but not enough. And then basically, I would like if you can give us first an introduction. What's Press Ganey mission and why it was founded and when it was founded and how it works?
Okay. So Press Ganey was founded in 1985 by two Notre Dame professors. One was an anthropologist and one was a statistician. And they wanted to help organizations understand how the patients perceived them in healthcare. And so I don't think we're going to be able to show slides, but Press Ganey is a data and analytics research and improvement company. That's what we do. We survey patients, providers, employees across the continuum of care. We look at patients' perceptions, employees' perceptions, physician perceptions, but then we also have clinical quality indicators that we look at. We have safety surveys and indicators. So from the patient experience, the clinical excellence, safety, and engagement, we look at all of those things and we put that data and analytics together and help organizations improve across all of those different domains.
When you read your book, there's many things that call my attention. One, it's about sometimes we feel that we can take care of the suffering of the patient with pain medications. Let me translate the question. Cuando uno lee el libro, uno de los primeros capítulos nos hace ver que nosotros como médicos a veces pensamos que el sufrimiento, cuando el paciente está sufriendo, pensamos en medicinas para el dolor y que el sufrimiento del paciente, not necessarily, it's because pain. How you see that?
So when we look at the correlations between the ideal patient perception of care and pain, for example, pain is not necessarily highly correlated, other than in the emergency department, patients want their pain to be controlled. But what we have found in looking at the data is what is much more important to patients is that we treat them as a person, not a diagnosis or a room number or a doctor's name, that we can make that connection with them. And we started talking about suffering a few years ago, and nobody, at least in this country, nobody likes to talk about suffering, because as a clinician, if you tell me my patient is suffering, I feel guilty. I should be doing something more. And so when we started looking at suffering, we recognized that there are two ways that patients suffer. There's inherent suffering. So even if healthcare were perfect, just the diagnosis and treatment alone causes suffering. And we can't eliminate that, but we can help. But then there is a lot of suffering we actually cause. We impose it on the people who come to us for care when we make them wait, or when we don't work well together as a team, or we don't provide clean, quiet, healing environments. Those things cause suffering too. And it happens every day in healthcare all over the world. And that kind of suffering we can eliminate. And this all became very clear to me when I became a patient. I was diagnosed with breast cancer, and I began to understand that suffering is something that we should talk about. But it's not about a score. It's not about a percentile rank. It's about understanding who that person who happens to be a patient at the moment is and what's important to them. And then it was brought home again 2 years later when my son-in-law was shot in the head in the line of duty as a police officer. And I was on the family side of that suffering. And there is so much that we can do that isn't hard. It's not rocket science. It's about acknowledging that people suffer and showing them that we care, and understanding that body language is as important as the words that we use, and that people want their care to be coordinated, and they want to have autonomy and some control, and that the most important thing that we can do is show them that real caring transcends the diagnosis or the procedure, that it is every single person has a life and a family and a job or hobbies or things that are important to them. And the most important thing we can do is find out one thing about them that has nothing to do with the reason they're there. And in putting those things into practice, we've seen that patients are more loyal to you as a provider or to the organization, and that they feel safe in your care, which is really the most important thing we can do.
Let me translate the last point.
Sorry.
Es muy importante porque ella siempre insiste que a veces el paciente, el dolor es importante, pero a veces no necesariamente aliviar el dolor es lo que el paciente al principio está buscando. Que a veces con tener el elemento de comunicación, o a veces el médico va a venir un poco tarde, pero el paciente está informado de lo que está pasando. El paciente se siente satisfecho porque se siente parte de eso. Y cuando el paciente existe la comunicación, uno de los ejercicios que nos hizo es que, y casualmente yo fui la persona que fue interrogada voluntariamente para hacer el ejercicio, donde ella demuestra que el personal de salud se le puede enseñar generalmente en 59 segundos, en un minuto, cómo crear ese vínculo. Y sobre todo ella promueve el hecho de preguntarle algo que no necesariamente esté relacionado con la historia, preguntarle algo más allá de eso, algo sobre la vida del paciente, un detalle importante que genere ese vínculo donde tú evidentemente generes un genuino interés por saber algo más de esa persona. I'm talking about the question that you usually make that is not necessarily related, but is the one that will create bounds because it gives more information about the patient.
Right.
Entonces, esa pregunta es clave donde, and also that you teach me, because I always was with the idea that that's something that you cannot learn. I was with the idea that you burn with that. If you don't have that human quality that you care about people, it's difficult to learn. But you made me clearly that this is something that we can train, that is something that we can learn, that even there is like a systematic points that, of course, if we do it genuinely, is not something that we're not going to fake that interest.
Right.
Because patient will note it that it's fake. But if we remember that we need to do those easy steps that is very important for the patient. Privacy, ask how he feels, ask how he wants to be named.
Right.
Okay, can you make some comments about that?
So when you think about the people who are taking care of patients today, many of them have never been a patient. And so we say things like be empathic and be compassionate, and they don't know what we're talking about because they think they're nice, right? But the problem is, if you've never been a patient, you really don't understand. And so one of the hospitals that I worked with, to orient their staff to the emergency department, for example, when they came in for orientation, they sent them out to the waiting room and they left them there for 4 hours and they didn't tell them anything. And then they pulled them back to a treatment room and they closed the curtain and they talked about them on the other side of the curtain. And the new employee had no idea what was going on. But at the end of the day, the preceptor walked in and says, this is what your patient goes through every day. Don't forget it. And those kinds of things leave a mark. So when you have someone who takes care of patients every day and you make them horizontal instead of vertical, completely at the mercy of the people taking care of them, and maybe they have an IV and you leave the call light on the floor and you leave the door open so they hear all the chatter at the desk, but they have no way of getting anybody's attention. They don't know what's happening, and it's scary. And so that's why we do what we do. We do what we do to make the people that we take care of feel safe in our care. It all boils down to that.
Wow. Estaba explicando que cuando empezaban los entrenamientos ponían a los participantes en una sala de espera por 4 horas sin decirles qué estaba pasando. Luego los pasaban a una sala de examen, cerraban la cortina y hablaban de ellos detrás de la cortina. Y al final del día le explicaban que esto es lo que el paciente siente cuando está esperando un ambiente desconocido, alguien hablando de ellos sin que ellos sepan quiénes son. Y cuando pasan de la posición vertical a la posición horizontal, así sea para tomarle una muestra de sangre, como están totalmente indefensos y cuando evidentemente es pasar por ese escenario. I was, you know, there's sometimes that or you get sick or some of your family gets sick. And I have a few months ago the experience that my mom was sick and I was with her in Miami. It was a very, very difficult situation because first, you're in a hospital where you don't know anyone and nobody knows who are you. Here at USC, they know who are you and people take care of you also because you have friends. And you know sometimes the way how to navigate these huge systems and how to make sometimes the appointment get faster because we have all that difficulties in these giant systems. And then I was in Miami alone and with my two brothers and one brother and two sisters around my mom. She was critical and I was like in 15 days, I fly back to Miami like 4 times. I went Miami, came back 2 days LA, go back Miami. She was getting sicker, I go back Miami. And then when I go Miami, I go directly from the airport to the hospital and I spend the night with her in the ICU. And I was surprised each morning that when they come to see her, again, they was asking the same questions. Students, PAs, residents, and finally the attending came. And she complained that she was having pain when they touch her legs. Everyone comes and touch it again. And I said, she already told the first one who came. Why you need to do it 4 times? Why do you need to ask questions that you haven't even see her record? And then at that point, I start thinking about it. If these rounds could be sometimes painful, if these rounds where they come and they make evidence when they ask a student or they ask a resident question that they don't have any idea, they make evident that they don't have any kind of communications, and you get worried because you say, what's going on? These guys don't know what they're going to do. I'm on risk or not, or I'm safe. And then
That's right.
I'm going to translate the question and then we're going to have the answer. Le estaba comentando a Chris que muchos de ustedes saben que yo hace unos meses pasé por un tema crítico con mi mamá en Miami, en el hospital, y como en 15 días fui 4 veces a Miami, al hospital, y yo estaba solo. Y es un hospital donde yo básicamente no conocía a nadie. Habían uno que otro amigo que nos ayudaba, pero uno está acostumbrado a poder navegar la situación. Y me encontré con la situación que cada vez que llegaba a Miami yo iba directo al hospital a cuidarla a ella a terapia intensiva. Y me encontraba en las mañanas cada vez que amanecíamos, que llegaban los estudiantes, los residentes, los asistentes de los médicos, y cada uno volvía a hacer las mismas preguntas. Cada uno no sabía lo que estaba haciendo. Había desconexión en la información. Y tú decías, bueno, ¿qué pasa? A veces uno se angustia al ver que no hay comunicación. Entonces me entró en ese momento la duda si estas revistas médicas donde a veces se hace evidente ese problema de comunicación, si ellos deberían hablar afuera, if they should talk before going in. I know that sometimes it's important they come in to make the patient part of the communication. Como que el paciente, siempre se ha pensado que hablar delante del paciente lo hace partícipe a él. I understand that he can be participant, but sometimes he can get more worried about it. And then how we should do this round, how the nurse should do this round, how frequently we should do this round. Because I was also complaining that there was a lady who come to clean the room at 1 a.m. She just came in, make all this noise, and they said, what's going on? So why they need to do that at 1 a.m.? Why they need to take labs at 5 a.m.? So, Chris.
Because the way that healthcare has evolved is that it is provider-centric. It's not patient-centric. And so they're just getting their job done. To them, it's just part of their day. It's not 1 a.m. at the time where you should be sleeping. And so I think we have to change that mindset in healthcare, that we have to become less provider-centric and more patient-centric. So that means fundamental change so that we consolidate rounding, so that we're all talking to the patient at the same time. Interdisciplinary rounds are so important because it demonstrates to the patient that we are talking to each other. We're all following one plan of care. We're involving them in that conversation. And that puts the patient at ease. It makes them feel safe. it makes the family feel safe. Because when you have that many people coming in and it's clear that they're not talking to each other, then the patient doesn't feel safe and the family doesn't feel safe. I'm sure you were afraid to leave your mom because
Yeah,
you weren't quite sure what was happening.
I think that maybe it was easier, and then we create a beautiful relation basically with the attendants, and I get they give me their phone numbers, and I basically text them, and of course
Right.
I get the way that I feel safe. Even when I came back to LA, I get a beautiful connection with them, and I keep that, and when they say any risk, I fly back. But sometimes I found that the interns and the residents, and they need to go to the room sometimes because they want to get everything ready for the round. But each time they go in, they ask the same question. Sometimes they don't know exactly. They have too much work. They did not have time to see the records. Sometimes they have a switch and they don't have time to review the charts. And that's why they come to the room to ask questions that you say, so I know exactly where. And then at that point, I say maybe it's easier that only the attending comes and interact, and be only only one guy who talk, and then to avoid miscommunication and to avoid because really it's painful that you feel that what's going to happen here. If I was not here, what could happen?
So did the interns introduce themselves as interns?
Sometimes they did not introduce exactly that's a very important question, because sometimes I was surprised that I saw, for example, it came a resident and it came a PA, and the PA started talking, and he looks elderly, that the fellow, and at some point I thought maybe this guy is the attending, and he spoke very fluid and very properly, and they say maybe this is the attendant. No, it was a PA. And
Right.
sometimes you don't know exactly who's really on charge. And then at the end, I ask him, well, basically, you're a resident, you're an intern, and then I found that and that's why it's a very important also point that you make in your book, that it's very important that we introduce.
Yes. Yes. So the example that I gave was when I was in the hospital and my first night post-op, someone in scrubs came in and she checked my armband and she messed with my IV, and she came around to lift my gown to check my dressing. And I said, "Who are you?" Because she hadn't introduced herself. It's so important. If that's an intern, then you know that he's learning or she's learning. And so for that person to say, "I'm Christy, I'm an intern and I'm learning, and so I may ask some questions that you've already answered, but it's so that I can learn and so that I can make sure to keep you safe." That probably would have made all the difference for you.
And for example, I also saw some nurses training another nurses. And you don't know how fantastic it was seeing that when you see some guy, wow, incredible. So passionate, training them how to move the patient. And I say, wow. And I ask her, how many years you have doing this, really training? And I say, that's the way that we should do it. How we really focus and train and do it with passion, that education to transmit.
Yes.
How they ask us that we need to have compassion, but how we get our tank full of compassion?
You know, I think that
Let me
so
translate
many.
the question.
Oh, I'm sorry.
Nos piden que tengamos todos nuestros sentimientos de afecto y compasión por los pacientes. Y yo le pregunto, ¿cómo hacemos nosotros para llenar nuestro tanque y tener siempre el tanque lleno de ese espíritu para cuando vemos a los pacientes?
So most of us went into healthcare to help people. That's why most of us are physicians and nurses and respiratory therapists. We want to make a difference. We want to know that what we do matters and that we make a meaningful contribution. If we turn healthcare into a task-oriented job, where all we're doing is coming in and accomplishing tasks and documenting those tasks, we lose the meaning behind what we do. When you make a connection with another human being and you are able to help that person, help them into this world, help them out of this world with dignity and all the other things in between that we do, then you know that you've made a difference. That's what makes this work meaningful. But if we turn it into nothing but a bunch of tasks that we have to do one by one, or a checklist, and that's all we do, then we might as well work at fast food or retail, because that's not why we do what we do. So to fill our compassion bank, number one, we need to know that we make a difference. And number two, we need to know that the people that we report to also know that we make a difference.
Yeah. It's not only that we feel that, we need to feel that the whole institution has
That's
this
right.
principle.
That's right.
Some people say that sometimes you don't do the connection with the patients because you have some self-preservation. Algunas veces nosotros decimos que we are very careful de no crear vínculos con el paciente como mecanismos de protección. What do you think about that self-preservation?
I think it can go too far. When I asked you, for example, when we did the demonstration, and I said, you know, what would you like me to call you? And is this a good time? And tell me what you would be doing right now if you weren't in the hospital. You know, whatever you told me, I could make that connection, and we can do that as a demonstration for this group too. But, you know, I didn't put myself out there when we had that demonstration. I just let you know that I was a human. We made that human-to-human connection, and now you know that I know you as Renee. So I think it's really important that we do that. And I think you can still maintain separation even as you make a connection.
Importante que tú puedes mantener esa separación o esa protección a pesar de generar esa conexión. You make an example that I always love to do it when I go inside a room, that I get a chair, I sit, and sometimes I ask my fellows to sit also, and then yo le estoy preguntando, que hay un ejemplo que ella puso, que yo muchas veces lo hago, que llego y me siento o agarro sillas y le digo al fellow que se siente, y el paciente inmediatamente siente como que I'm relaxed. Can you explain all that?
Sure. So if you were a patient sitting in a chair or even lying in the bed, I would sit down and I would say, hello, Dr. Sapel, how are you? I'm Christy. I'm going to be your nurse today. Tell me what you would like me to call you. What should I call you? What should I call you?
Renee.
Renee. All right. Very good. Is this a good time?
Yeah.
Okay. You know, Renee, we talked at Bedside Shift Report this morning about the changes in your diet and the procedure you're going to have tomorrow. And I want to answer any questions that you have about that. But I've never taken care of you before. So when you're not in the hospital, what do you like to do? What brings you joy?
Well, I like to go traveling.
Traveling. Where do you like to travel?
Well, I like to go to India, for example.
India. Very good. When was the last time you went to India?
I was there 4 weeks ago.
Oh my gosh. So very recent.
Yeah.
So where in India?
I went to Goa for a meeting.
Oh, very good.
Yeah.
Did you have time to taste the local cuisine or get a piece of the culture?
We went like 2 days before with some friends, and we tried different restaurants in Mumbai.
Oh, very good.
Yeah.
Very good. I've never been to India, so I'm sure you have photos. I'm sure you have lots of stories, even though your time there was brief. So I'm going to be in your room about every hour. So the next time I come back, I want to see some of the pictures and hear some of your stories, because I'll be here about every hour. But in the meantime, I'm going to ask you a lot of questions. I want you to ask any questions that come to mind, because we're in this together. Okay?
Wow. acaban de ver un ejemplo de conversación, cómo puedes generar conversación genuina, interés en el paciente, en algo más que lo trae, qué le genera a él ganas de vivir, qué lo motiva a él, y en ese momento se genera una conexión donde ya sabes un poco más del paciente. Yo siempre les pregunto al paciente, ¿qué hace? Un poco para saber qué tipo de actividad física hace, pero para saber qué le importa en la vida, cuántos hijos tiene, si tiene nietos, cuál es su visión de futuro, porque esa visión de futuro es la que lo mantiene vivo. Y muchas veces esa es la diferencia entre un paciente que quiere vivir porque tiene visión de futuro.
And it only takes 56 seconds to do that.
Se dieron cuenta
It's
que
not like it takes a lot of time.
un par de minutos, 50, 60 minutos, para establecer esa conexión, que no hace falta tenerlo. Y es muy importante, because it's very important, this is not a script.
Right.
Y le estoy preguntando que esto no es un guión. Y esto tiene que ser bien claro que esto no es un guión. Is something, any comment about the scripting this?
Well, you know, scripts come across as just that, scripts. So when I like to tell stories. And so when my son-in-law was in rehab, everybody who came into his room said the same thing. It was clear that they were scripted, and it came across as not authentic or genuine. They did great work, but I really didn't feel like they cared because they all said the same thing, exactly the same thing. And so I think it's really important that you figure out how to make that connection your own. So you might ask when you're not in the hospital, what do you like to do? You might see something in the window, a bouquet of flowers, and say, oh, who sent you those flowers? There are lots of kinds of questions that will allow you to build or connect with whatever the patient says. You have enough experience as a person, as a human, to connect with whatever they tell you. And so make it your own. The idea is just to connect with them around something that has nothing to do with the reason they're in care. So they know that you see them as a person and not a diagnosis or a procedure.
I remember your book that you give an example that a nurse comes and it's very typical in US that you start calling the people by his first name.
Right.
And sometimes you don't ask how they're going to be. Can you give us the...
Yes.
story?
So the nurse the young nurse walks into the patient's room, and she says, "Hi, Frank, how are you today?" And he gets very angry and red in the face and says, "Get out of my room. Go get the head nurse." And so she goes, she doesn't understand what happened. And so she goes and gets the nurse manager, and the nurse manager says, "Please tell me what happened." And he says, "That little chippy called me Frank. Nobody calls me Frank. My wife doesn't even call me Frank. I'm the judge." And it was just, and the nurse manager says, "Oh, I'm so sorry that happened. You know, Christy's one of our best nurses. Please let her come back and try again." And so she comes back in and says, "Judge, I'm so sorry. I should have asked you what you wanted me to call you. How did you get the name Judge?" And she was able to repair the connection. But it's little things like that. When you have no control over anything but your name and how people look at you and talk to you, that becomes really important. It's not really that important to us. We don't care. But for that person in the bed who has no control over anything else, simply asking what they want to be called becomes very important.
I'm going to go back about the autonomy and about some examples, but I want to translate this. Yo le preguntaba que en este ejercicio, muchas veces en Estados Unidos, siempre le preguntan al paciente, ¿cómo quieres que te llame? ¿Cómo quieres ser llamado? Porque a veces aquí tienen la tendencia siempre a llamarte por tu nombre, por el primer nombre. Y este es un ejemplo de una enfermera joven que entró a un cuarto y veía que el señor se llamaba Frank algo y le dijo de una vez Frank. Y el paciente se molestó y la mandó a salir del cuarto y pidieron que viniera la jefe. Y el señor le dijo que le decía a la supervisora que ni siquiera su esposa lo llamaba Frank, que lo llamaba señor juez. porque era un juez. Y, y no es el hecho, evidentemente, de que se molestaba. Esto trae a conversación un elemento importante, que es que los pacientes cuando están sin ropa, sin nada, acostados, pierden su autonomía, su capacidad de decisión. Y esos pequeños detalles, ellos se pegan a eso para sentirse de alguna forma que mantienen su autonomía. What other examples we have that it can reflect how we can preserve, how can give some autonomy to the patients? Entonces le estoy preguntando, ¿qué otros ejemplos para un paciente que está indefenso podemos darle para ayudarlo a que él sienta o a que pueda tener algo de autonomía?
There are lots of things that we do in healthcare that we just do as a matter of course. We walk into the room and we put the blood pressure cuff on an arm. There's a choice in that. We can ask the patient, what arm would you like me to take your blood pressure on? Do you want ice in your water or no? If you're not hungry for lunch, we can put your lunch aside, and when you're hungry, you let me know. When we walk this afternoon, do you want to turn left or right? Things that don't matter at all to us in healthcare mean a lot when you have no control over anything else. So any choice that we can provide anywhere along the way makes a big deal to the patient because they have no control. We take their clothes, we take their stuff, we tell them who can visit and when they're going to eat and when they're going to walk and when they're going to go home and what they can do when they go home. So we take away all control. Any choice that we can give is important to give back some control. Narrating care is another thing that we can do to give back some control. We know why we do things, but they don't. So to be able to talk about what we're doing as we do it is a way to give back some control.
Es importante de alguna forma darles algo de retornarles el control. Y ejemplos es, por ejemplo, que para nosotros no tenga ninguna diferencia médica, que tomar la atención en cuál brazo prefiere, de qué lado quiere pararse de la cama, a qué horas quiere, si quiere dejar la comida en la mesa y que se la coma cuando tenga un poco más de hambre. O sea, todas estas medidas que de alguna forma lo estamos haciendo al partícipe de la decisión y le estamos devolviendo la posibilidad de que él tome de alguna forma parte del control que le hemos quitado cuando tomamos todas las decisiones, lo acostamos, se desnuda, lo ponemos y él no tiene control sobre esas decisiones. We can spend hours here because I have es impresionante lo importante I really enjoy, you don't know how much reading and understanding that this is a whole process. And I want to, if you can have some minutes to explain the importance, not only of quality of care that is obvious that many hospitals have it. It's not about safety because everybody now is working about safety. But what's important of this experience and how this experience show numbers and why the hospitals are now and the CEOs are interested in the quality of the experience.
Right. Well,
I'm sorry. Estoy preguntando por qué es importante, aparte de la seguridad del paciente, por qué es importante la calidad. La calidad hoy en día es obvia. Ya el paciente supone que el médico que está viendo, sobre todo en estos grandes hospitales, es obvio que tiene que ser de buena calidad. Y es obvio que tiene que haber las medidas de seguridad. Pero lo que es ese viaje por esa experiencia de cómo va a ser tratado es otro tema distinto. Y le estoy preguntando, ¿por qué hoy en día los hospitales le prestan tanta atención? Why also the reimbursement now is also concentrated in not only in the quality? ¿Y por qué hoy en día los sistemas de reembolso de las aseguradoras han cambiado?
I think, well, having reimbursement tied to the patient experience helps bring it to the forefront to CEOs. However, what we have found now in looking at clinical quality, so things like bloodstream infections, urinary tract infections, falls, and pressure injuries, and looking at those indicators at patient experience, at engagement, what we have found is those things all impact each other. So one of the slides, and you're welcome to send the slides to your colleagues, but I'm gonna read here. See this slide now?
Yeah.
Recognize and act on the intersection. All right.
Yeah.
Let me see if I can make
Perfect.
this bigger for you. Can you see the whole slide now?
Yeah.
Yes? Okay. So what this shows is how all of this works together. If you look in the center, organizations with top patient experience have 24% lower bloodstream infections, 30% lower MRSA rates, 30-day readmissions are 3% less, and their length of stay is 1 day less. When you think about for example, top engagement, organizations with top engagement have lower bloodstream infections, lower C. diff rates, better safety scores, and almost a full day length of stay less. So you can see on this slide that all of these things work together. The patient experience is not about making people happy or being nice. The patient experience impacts clinical quality. It impacts their perception of safety. It impacts the feeling of engagement for staff. And so it all works together. Patient experience is about the clinical, the operational, the cultural, and behavioral aspects of the care we provide in every setting by every person. And I think that's what because of data like this, we've been able to show CEOs that the patient experience is not about being nice. It's not about having being at the 90th percentile. It's about understanding that the patient experience drives everything. It drives engagement of the staff. It drives the perception of safety. It drives clinical quality. It's everything we do in healthcare.
It's difficult to translate it. So perfectly, wow. Es definitivamente que esto no es hacer a los países, no es ser el más simpático y simplemente ser simpático con los pacientes. Es que definitivamente todo este elemento de comunicación y crear empatía y crear vínculo con el paciente repercute en todo. And I think that at the end is all that quality of communications. Patients follow instructions, they understand. Y es porque el paciente sigue instrucciones, sabe lo que hay que hacer, porque creaste un vínculo. You take your time, and he wants to learn because you explain to him exactly what's going on.
Right.
I remember from your talk, there was an example that you asked us as attendings to always, when a resident or a fellow is presenting you a case, to always ask him also a funny or something different from the patient. Something that the patients,
yes,
because that to check that if they're doing really a good connection with the patient. I'm going to translate it first, and then you're going to explain that.
Okay.
Yo recuerdo que uno de los ejercicios que nos hizo en la conferencia fue que nos pedía que cada vez que un residente o un estudiante nos presentaba el caso, el fellow llega y dice hemoglobina tanto, drain tanto, creatinine, y todos son números, everything is numbers. Pero nunca hay nada que hay del paciente. Entonces, que nosotros les preguntáramos a ellos, ¿qué hace ese señor? ¿Cuántos hijos tiene? Algo sobre la vida del paciente, para obligarlos a que no vieran al paciente como una presentación de una secuencia de números, que se dieran cuenta que nosotros estábamos pidiendo información de ese ser humano, something else. We was asking for some more information about the human being, not necessarily numbers.
Right, right. Tell me something about that patient that has nothing to do with the reason they're here.
Wow.
Because if you can do that, you know that they are connecting. If they can't do that, they're not. You will never improve the patient experience if you can't connect with the patient.
Wow. Díganme algo del paciente que no es la razón por la cual vino. Y eso los obliga a generar conexión y los obliga a entender la importancia de la conexión. Wow. Bueno, yo quería, Chris, I just want to say thank you. If you have any remarks that you want to comment, Basically, I want to say thank you very much. You have changed. I have now your book of one of my reference. De verdad, I invite you to get the book. Es el antídoto para el sufrimiento. Y es definitivamente porque nosotros, without intention, sometimes we create suffering. I remember it's your book available in Amazon. Yeah, I got it from Amazon. Yeah, that's exactly how I get it. I get it in Amazon. The book is so nice to read it. It's so full of examples and stories. And I remember one because it caught my attention also that when I was waiting, they have to do an emergency surgery to my mom, and finally she passed away. It was very difficult. But I was in that waiting room for hours. And I remember when you mentioned that, I don't know why, but we make these waiting rooms without windows, very small, only few chairs. And you have to spend hours waiting to somebody, a doctor who comes to the room. You don't know if it's going to talk to you or who's going to talk. And you see people crying, some people happy, and you're just waiting there. And it's something so easy that we can make it better. And we can make something that it's not a computer with names, surgeon's going to come. O sea, we need to pay attention to that. Le estaba comentando, en el libro, ella cuenta una historia de que las salas de espera en las salas de cirugía son unos cuartos pequeños, sin luces, no están preparados para eso. Las familias llegan, por supuesto, nosotros éramos familia latina, Latin family with my sisters, my brother, we was all there. And it was so sad that there was not a special place to wait. And I was in the halls waiting to see if they come from the OR. And we need to fix that. So we need to remember that there are families. And of course, there are different families. There are families that they give you the phone number. Call me when you're done. And I feel so sad sometimes. And there was something different for me when I came from Venezuela to here. First time I came out, I say, well, I understand they're working. I understand sometimes they're far away. And there was a phone number. You just need to call and talk to the family. We are different. So we are used to come. My family came from Venezuela. I go from LA, and we was all of them around my mom in Miami. And sometimes I remember here, I have a patient, I have a lot of international patients. They came one from Venezuela, and he came with 12 relatives, even one that was pregnant. And when he went out to walk, the 12th family was walking. And the patient relations come to take some pictures of them because there was a record how many relatives come around a patient to walk. 12. And I said, well, we need to understand that there are different cultures, and we need to be prepared for that. What are your remarks?
I think we should ask. Tell me about your family. Tell me why you want 12 family members with you. People want to talk about themselves. We just have to ask the question and give them the opportunity to talk about themselves because they want to. And then we learn more about them that lets us take better care of them. And I think it's important. We need to do that. And it doesn't take long, but it does take practice. And I think we need to give people time to practice and understand not only what that does for the patient, but what that does for them as a provider. I think that's really important. It doesn't take very long. Take 5 minutes at the beginning of every month meeting to allow people to practice how to make that connection and to give each other feedback. We don't do that enough.
I feel that I was commenting with or talking with my partners that we should get you to all the introduction welcome when we bring residents and fellow on board. And also when they do all this introduction talking about the hospital, I think it's very important that we explain that well, we have hours here. I really want to, because also we have a very good about the mission and the vision of the hospital. But I think we have much of your time. I really are Thank you very much for the opportunity.
Thank you.
I feel
Thank
that
you.
I'm going to send these slides to anybody who has them. Juan Arriaga is from Mexico. He say, very, very nice talk. Congratulations. We have many congratulation message. One, I think it's very good opportunity if you can talk to editorial companies. And I think that's going to be a piece of incredible book that we need to translate it. And we need to also teach our residents and fellows how important is try to avoid this pain, this suffering that the patients don't need to go over that.
That's right. That's right. Thank you.
Chris, thank you.
Thank you. It was my pleasure. Thank you.
My pleasure. Thank you. Thank you. Thanks all my friends for joining us. And we're going to put this conference in YouTube that they can have another time to read it. I'm still reading Reynaldo Gomez. Very, very nice talk. Reynaldo is the vice president of SIU, of the International Society of Urology.
Ah, very good.
The whole is the vice president. And I think that this is something that we need to invite Chris also to our international meetings. This is something we need to do. We need to do postgraduate courses to teach the residents and fellows how they need to interact and how they can really communicate with patients.
That's
Chris,
right.
thank you again. Thank you.
Thank you.
Okay.
Thank you.
Bye.
Stay safe and well. Bye-bye.